So today we will talk about patella tendon anatomy, as well as a function of the patella tendon, injury, stages of healing, and pretty much how to treat it with exercise progression. So a typical runner coming in with patellar tendon type pain says, "Hey, I was running and increased my volume recently," or just increasing the intensity of the runs. They sometimes come in with an achy knee. Now, the most common issue we see with that is patellofemoral pain or runner's knee. That's a kneecap issue. But it could also be patella tendon pain, which is right below that. And I'll show you the anatomy. And I probably see it more with sprinters than longer distance runners. So just to get us oriented, this is the patella tendon or ligament. By definition, a ligament is bone to bone. So technically it is a ligament, but we all call it tendon. It attaches from the kneecap and then goes down and inserts on the shin bone of the tibia. So it's that structure right below the kneecap that you can palpate with your hands. If this is an issue, that area is often tender. This is kind of a good side view of how intimate the relationship is with the kneecap and the patella tendon. The patella is the kneecap that can sometimes get overloaded with volume, very similar to patella tendon. And so the cartilage on the kneecap could be irritated. And this could be confusing for a lot of people. Is it patella tendon or kneecap? But typically with patella tendons, we see this in younger males, 15 to 30 years old, and it's coming from more jumping sports, tennis, basketball, volleyball. Running's in there, and I said probably usually more sprinting type activities. So it's usually associated with load of that tendon. Well, how do we determine which one it is? Well, it's fairly straightforward. And by the way, they could be both at the same time. So it's not usually one or the other. Sometimes it could be both. One differential factor is it's painful when you sit for long periods of time. Where it's patella tendon, it doesn't usually get painful when you sit for long periods of time. The reason for that is the cartilage behind the kneecap is being compressed along the femur for extended period of time, causing some irritation. So if sitting is painful, it's probably more the kneecap that's an issue as opposed to the tendon. And what's clinically useful to see if it's a tendon is simply just touch it. Does it hurt to touch the tendon? And you have to dig on it a little bit, but you might find a sore spot here or there. Now, I'm not going to get in details here, but there's something called a fat pad underneath the patella tendon that could also be irritable. That's also less common than patella tendonitis, so I won't get into it, but just know the differential between different structures is possible in the front of the knee. Also, with kneecap pain, it tends to help when I unload the kneecap. So if you have a sleeve and it relieves the knee pain, it's probably more the kneecap causing the issue. We could tape the tendon, and that could also help alleviate it. So let's talk about this tendon. Usually from a pathophysiology standpoint, the tendon has disrupted fibers. It's secondary to overload. So the patella tendon, it shows a clean collagen fibers lined up in a nice orientation. And so they can respond to stress very well. If you have a chronic tendon, not just patella tendon, it could be the Achilles tendon, the shoulder, the supraspinatus tendon, they have a more disorganized orientation of their tendon fibers after a strain or disruption. I actually did a study for this on the posterior tib tendon and how it responded to load over time to repair it. What was interesting about that research study is that the people got strong on the posterior tib tendon, but the morphology of the tendon didn't quite change the way we expected. We don't know how long it takes for this reorganization of the collagen or the protein in the tissues to reorganize into a healthy manner, but we know that people do get stronger and are less symptomatic pretty quickly. And that was 6 weeks. And usually it's 4 to 6 weeks range for rehab. When we come in for anterior knee pain, if we think it's patella tendonitis, we want to differentiate between tendonitis and tendinosis. And it's relatively easy. Tendonitis, the itis means inflammatory process. That's usually a high acute pain, and it's usually pretty quick, sudden onset. And as you run, the pain increases. That's tendonitis. Tendinosis is more of a chronic degeneration of the tendon that hasn't rehabbed fully. So like the slide I showed you with the disorganization of that tissue, that's more of a tendinosis that just hasn't healed properly or got strong enough to withstand the forces of running. So with tendinosis, it's more of a low pain. It's chronic pain, so greater than 3 months, but you don't see a lot of redness or swelling. And the interesting thing about tendinosis is it starts to feel better as you train. And again, there is overlap too. There's kind of like a middle stage as well. But I just want to express this so you know when you do have an injury, how to approach it. With tendonitis, it's more of an inflammatory condition. Tendinosis, it's more of a chronic disorganization of the tissue that needs to be addressed through loading. Give you some perspective of the healing time. When you have that initial onset, on the very left is a bleeding, and then that's inflammation or inflammatory process. So that's more the tendonitis. But as it heals, the pain gets lower and the tissue begins to get stronger over time. But again, it takes weeks to months to get back to really strong tissue. So just because you don't have a lot of pain doesn't mean the tissue is fully strong. So for tendonitis, if it is indeed an acute inflammatory condition, resting is obviously the most obvious answer to just let the tissue heal. And when we say rest, it could just be active rest, like go biking or maybe run not as long or not as intense. Depends on the acuity and the person, but you just have to modify your current volume or intensity to give the tissue some time to heal. I often do light exercises. Again, biking is pretty common because it doesn't put a lot of stress on the tissue. And I do some isometric exercises like knee extensions. They might hold that for about 30 seconds, and that helps with the pain response. If it's bad enough, I could tape to unload the tendon. And as always, I say ice would help reduce the pain and inflammation. And people can take anti-inflammatories as well. Generally, it's a couple, 1 to 2 weeks, depending on the intensity. And then we start to reload after that. Just to note too, some runners stop running or modify and they still have pain or an tendonitis type of condition. And then I say, well, what else are you doing? And then I find out they're playing volleyball or other activities. So just because you're not running, you have to be mindful of the other activities that could impact your knee as well. Tendinosis, they get better pretty quick. So when you're in this category, I usually load the tendon into a little bit of pain. So unlike tendonitis, where you don't want the pain, tendinosis, it's okay to have some pain. So when we're training to reload this tendon, I say, here are my ground rules. Less than 3 out of 10 in pain, and the pain does not linger the next day. If it does, then we kind of modify it. And so we load it through squats, split squats. This is a single leg squat example. Usually it's 3 sets of 6 to 8 reps into slight discomfort. When that starts to feel better, as the tissue begins to adapt and get stronger, then we add some load. Then we add some jump squats and more vigorous activity. At this stage, when they have unloaded for a bit and then get back into loading, I usually do a walk-run program. And so a typical issue I see with a lot of runners is once they start to feel good, they go running they were doing right before. They go too hard, too soon, too fast, and the pain might come back again. So I tend to be a little more conservative when we go back to running. We're starting with the walk-run and then full running without a lot of intensity and then intensity after that. Some protocols, just to mention, depending on what you look at, some have loading most days of the week, some 3 days a week, some with more pain, So it's kind of all over the map. But what I found for me clinically is stick to that 3 out of 10 range. I say if it's not too threatening, keep going. And if it doesn't linger, that's okay. Tendinosis, it responds well to eccentric contractions. Concentric, just by definition, I just want to make sure we're clear, is a shortening of the muscle. So if I have the bicep curl, I do this. This is shortening. That's a concentric contraction. If I were to slowly elongate the muscle under load, that's an eccentric contraction. So when you slowly load down into the squat, the quad muscle lengthens, the tendon lengthens. So that's an eccentric contraction. So usually I go lower about 3 seconds, 3, 2, 1, to get tension over time for the tissue to respond and then come back up. Some people just strictly do eccentric and then bypass the concentric through like assist or whatever. It doesn't really matter too much to me. But just so you know, when people say eccentric, that's a lengthening of the muscle under load. And in the gym, some people may call it negatives. So these are the types of loads I have. And again, there's millions of examples, but squats is a very basic one. How do you feel? If it's some pain, we stay there for a bit. When they adapt, we add weight. Then we do split squats. I love Bulgarian squats for a lot of my runners. And then we go to squat jumps, which is even more load, and then single leg jumps. When you run, every time you land, it's about 3 to 4 times your body weight. So there's a lot of load going through the system. So we have to increase the loading capacity of your tissues, the tendon, to accept the forces placed upon it. There are other related factors to tendinosis that I didn't get to in this presentation. But I just want to emphasize that training error is a huge issue that we see, going too hard, too soon, too fast for the tissues to adapt. Other structures are weakness in the quad, ankle mobility deficits, as well as glute weaknesses. 3 to 4 weeks after you begin volume increase, you may not see the issues for that until 3 to 4 weeks later. So a lot of people get confused, like, oh, wait, I don't remember doing anything recently. But then when you go back, oh, when did you increase your training? And so it may not happen right away, but if you look back enough, you see a common pattern there.